Imagine walking out of a rhesus bay. Your adrenaline is just, it's spiking. Your heart rate is completely elevated.
You're completely wired.
Exactly.
Yeah.
You have just spent the last 45 minutes managing a catastrophic trauma. And you are finally heading toward the staff room to just decompress for a minute.
Which is incredibly rare in itself.
Right. But the second your hand touches the door handle, your pager goes off.
Oh, the absolute dread of that moment.
It's the worst. It's an urgent request to review an IT procurement policy for the new departmental software. And then straight away, that's followed by a message from a ward nurse asking you to review a completely non-urgent routine blood panel for a patient who is perfectly stable.
Completely stable, yeah.
So what do? I mean, do you answer them? Do you turn around and walk back into the fray, or do you keep walking into the staff room?
Yeah.
Today, we are dismantling the architecture of that exact moment.
It's a moment every single clinician listening knows intimately.
Absolutely. We are aiming this deep dive directly at you. The mid to senior clinicians, the orthopedic consultants, the medical professionals who are currently navigating the absolute thick of your careers. We are dissecting the concept of clinical boundaries.
And we really need to.
We do. Because the goal today is to establish a rigorous, grown-up framework, one that reframes boundaries not as this trendy excuse to avoid work, but as a critical biomechanical tool for sustaining high-level patient care over a 30-year career.
The scenario you just described, that feeling at the staff room door, it captures the immense cognitive dissonance that really defines modern medical practice. I mean, the conversation around clinical boundaries has become, without a doubt, the single most discussed topic in physician well-being.
Oh, everywhere you look.
Everywhere. Yet it remains the most deeply misunderstood. The discourse is just heavily polluted by conflicting ideologies that, frankly, offer absolutely zero practical utility for a senior clinician standing in a corridor with a buzzing pager.
Zero. It feels like watching a pendulum swinging wildly between two completely unsustainable extremes. Like, on one side of the swing, we have the cure-all camp, right?
Yes, the wellness industry approach.
Exactly. It's heavily influenced by the modern wellness industry that's just infiltrated medical culture. The narrative dictates that boundaries are the absolute, definitive antidote to physician burnout.
Which is a massive oversimplification.
A huge one. The advice is entirely subtractive. It demands that you just say no to more things. Stop checking your messages after hours, categorically refuse to let junior doctors have your mobile number, completely ignore administrative requests the second your contracted hours end.
Right.
It commodifies the concept of, and I hear this phrase all the time, protecting your peace. And it applies it to an environment that is, by its very nature, inherently chaotic.
And you can see why that narrative is remarkably seductive, especially to a clinician who is already experiencing the physiological and psychological onset of burnout.
Because they're desperate.
They are. When your central nervous system is chronically flooded with cortisol, the brain desperately seeks binary solutions to complex systemic problems. It wants a simple switch to turn the stress off.
Yeah, just tell me what to stop doing.
Spot on. The cure-all camp offers this illusion of control. It suggests that if you simply build enough walls, the systemic pressures of the healthcare environment will magically dissipate. But it ignores the fundamental reality that in acute medical specialties, the work does not disappear just because you refuse to look at it.
It just sits there waiting for you. Or worse, it falls on someone else. But then the pendulum swings entirely in the opposite direction, straight into the martyrdom camp.
The old school.
The old school. This is the entrenched historical medical culture, very much rooted in those 19th century Oslerian ideals of what a physician should be.
The infallible doctor.
Right. In this paradigm, boundaries are viewed as inherently selfish, like almost a violation of the Hippocratic Oath. The prevailing belief is that true, dedicated professionals always answer the call, regardless of the personal cost.
The patient absolutely comes first.
Even if it means the systematic destruction of the clinician's own life. The assumption is that clinical work simply cannot fit into a structural box, and attempting to contain it is, well, it's a sign of unprofessionalism. Or worse, clinical weakness.
And we have to acknowledge, I think, the historical utility of that martyrdom culture. I mean, it built the modern medical system as we know it.
It did.
But it relied on a model of healthcare that no longer exists. A model with lower patient volumes, significantly less administrative bloat, and a completely different societal expectation of the physician.
You didn't have a pager going off every 2 minutes for compliance modules back then.
Exactly. You didn't have an overflowing inbox. Both of these extremes, the purely subtractive wellness model and the infinite capacity martyrdom model, they both contain a microscopic grain of truth, which is why they persist. But fundamentally, both are dangerously incomplete.
So where does the truth actually sit?
The actual workable reality for an orthopedic surgeon, or really any senior physician trying to survive and thrive over 3 decades, it lives in the messy middle.
The messy middle. I like that, but the messy middle demands a level of operational nuance that a high-stakes, high-pressure clinical environment actively resists.
Absolutely.
When you are managing a busy trauma list, you do not have the cognitive bandwidth for nuance. You default to heuristics, you default to simple rules. And because this conversation has become so polarized, most clinicians are just left completely stranded without a usable operational framework.
They're guessing.
They're totally guessing. So we see reflexive boundary setting that ultimately damages patient safety and fractures multidisciplinary team relationships. Or we see reflexive boundary rejection that fundamentally destroys the clinician's health.
Which is why we have to start by tearing down the defensive, reactionary definitions we've been taught.
Okay, so let's tear them down. If a boundary is not a total withdrawal from the work, and it's not a total submission to the work, what is the actual mechanical definition of a true clinical boundary?
Right. So in the specific context of high-level clinical work, a boundary is a conscious, premeditated decision about what a clinician will and will not do, when they will do it, and under what specific conditions.
Okay.
It is an architectural decision about how you deploy your cognitive and physical resources.
I hear that, but framing it as setting conditions in a high-stakes clinical environment, it sounds a bit like you are building a massive brick wall between yourself and the multidisciplinary team.
It does sound like that at first glance.
Because if I am running a trauma center, right, and someone brings me a complex, unstable pelvic fracture at 4:55 p.m., and my predetermined condition is that my shift ends at 5:00 p.m., that wall feels like a total abdication of my clinical duty. I mean, the patient's physiology does not care about my psychological boundaries.
And that reaction right there highlights the exact misconception that prevents clinicians from adopting this framework. We must draw a severe, clear distinction between a wall and a structure.
Okay, a wall versus a structure. Break that down for me.
Think about it architecturally. A wall is a defensive mechanism. Its primary purpose is to blindly keep elements out. It is opaque, it is rigid, and it fundamentally halts all forward momentum.
Right, it's a barricade.
Exactly. If you build a wall around yourself in a clinical setting, if you simply drop your pager and walk out at 5:00 p.m. while a patient is actively bleeding, you are no longer practicing medicine. You are hiding behind an administrative technicality.
That's a great way to put it.
But a structure is an entirely different engineering concept. Think of the scaffolding of a building or, the biomechanical architecture of a healthy joint.
Something that supports weight.
Precisely. Structures organize how and when load-bearing engagement happens. They facilitate movement, they support the immense weight of the work, and they create predictability within a chaotic system.
So a wall stops the workflow, whereas a structure channels the workflow so that the load is distributed evenly rather than fracturing a single point.
Spot on. A healthy boundary dictates the terms of engagement so that the engagement can be of the highest possible clinical quality. And for a boundary to function as a load-bearing structure rather than a defensive wall, it has to meet 4 specific criteria.
The 4 pillars. Let's go through them.
The first mandatory requirement is that the boundary must be principled, not reactive.
Reactive boundaries. We see these all the time on the wards, don't we?
Constantly.
It's the consultant who usually answers every single WhatsApp message instantly, day or night. But then on a particularly horrific Tuesday, after 3 complex operations and a frustrating management meeting, they receive one more non-urgent query from a junior registrar.
Just one tiny question.
Right. And they suddenly declare, I'm not taking any more questions from anyone, and they just switch their phone off. That is an emotional reaction masquerading as a boundary.
Yes. And it creates immense clinical risk because it is entirely unanticipated. It creates chaos because it violates the fundamental requirement of predictability in a high-risk system.
So what does a principled boundary look like in that scenario?
A principled boundary is established during a state of parasympathetic calm. It requires proactive, strategic thought. You sit down during dedicated administrative time, removed from the immediate pressures of the ward, and you decide your operational parameters.
You decide the rules of the game before you're playing it.
Exactly. You decide how you will manage out-of-hours imaging reviews or how quickly you will respond to non-urgent emails. Because the logic behind the boundary is thoroughly vetted in a state of calm, it possesses the structural integrity to hold firm under the immense pressure of a chaotic clinic.
The principle survives the test because it was engineered before the stress test ever arrived.
Yes, which leads perfectly into the second pillar. If a reactive boundary causes chaos because it is unanticipated, then the logical countermeasure is absolute transparency.
Because a principled rule is totally useless if it only exists inside the clinician's head.
It's worse than useless. It's actively damaging.
Right. The entire multidisciplinary team, the registrars, the ward nurses, the administrative staff, they all must know the structural parameters.
Absolutely. Hidden boundaries that are sprung on a team in the moment are not boundaries at all. They are operational inconsistencies.
Yeah.
Consider the cognitive load placed on a multidisciplinary team by a hidden boundary. Imagine a senior consultant secretly decides, I am no longer going to review non-urgent postoperative imaging after 6:00 p.m. to protect my evening recovery time.
Which is a fair principle.
Very fair. But they fail to communicate this operational change to their registrars.
Oh, that's a nightmare for the registrar. The registrar's experience of that hidden boundary is pure anxiety. Because they send the scan at 6:15 p.m. They wait. They check their phone every 5 minutes.
Their cortisol begins to rise.
Exactly. They assume they have done something wrong or that the consultant is angry with them. Their cognitive focus is completely pulled away from the other patients on the ward because they are trapped in this awful anxiety-inducing limbo, just trying to decode the consultant's silence.
And that hidden boundary actively erodes psychological safety and trust within the team. High-functioning clinical teams rely heavily on predictability.
You have to know how your consultant operates.
Right. When a senior clinician's behavior becomes erratic due to uncommunicated internal rules, the team cannot rely on them. The juniors end up spending more cognitive energy trying to navigate the consultant's mood and unstated rules than they do managing patient care.
Which is incredibly dangerous. Transparency just removes the guesswork. It allows the boundary to function as a visible piece of scaffolding that the entire team can navigate around efficiently.
Precisely. So we have principled and we have transparent.
Okay, but here's the pushback. Medicine is dictated by unpredictable human biology. You cannot transparently schedule a ruptured abdominal aortic aneurysm or a massive hemorrhage.
You certainly cannot.
So if I have a perfectly transparent, principled structure that dictates I leave the hospital at 5:00 p.m. and at 4:50 p.m. a patient crashes, I cannot simply point to my transparent principle, tap my watch, and walk out the door. The structure has to account for the biological reality of the work.
Which introduces the third pillar, the necessity for durability over rigidity. A clinical boundary must be engineered to flex without breaking.
Flex without breaking.
In material science, there is a difference between yield strength and ultimate tensile strength. A healthy boundary has a high yield strength. It can absorb the shock of an unexpected clinical crisis, stretch to accommodate the emergency, and then return to its original shape once the load is removed.
It requires professional maturity, doesn't it? And situational awareness to make specific conscious exceptions without permanently unraveling the core rule.
Exactly.
So if I stay late to manage that sudden hemorrhage, I am not suddenly establishing a new permanent precedent that I am always available until 8:00 p.m. for any minor ward issue.
No, absolutely not.
The structure remains intact. I simply opened a specific temporary gate to address a critical system failure, and then I closed the gate behind me.
The exception is explicitly recognized as a deviation from the structure, not a destruction of it, which naturally leads to the fourth pillar, the ultimate litmus test for any boundary set within a healthcare environment.
The big question.
The singular question every clinician must ask themselves is, does this specific boundary exist in service of the work?
In service of the work. See, that is the exact point where the modern Instagram therapy version of physician well-being completely derails.
It completely falls apart.
Because a boundary must make you more capable of executing your clinical duties over an extended timeline. If a boundary isolates you from your team, degrades your technical skills, or directly causes patient harm, it is not a boundary.
No.
It is an evasion of duty.
And that is the dividing line between necessary structural protection and avoidance dressed up in the language of wellness.
Avoidance dressed up as wellness.
We have to dwell on this distinction because it is arguably the most uncomfortable truth in modern clinical practice. We are witnessing the insidious weaponization of therapy language.
Oh, weaponized therapy language. It's everywhere.
Clinicians are using highly polished phrases, talking about honoring their capacity or protecting their peace, to justify withdrawing from the difficult, uncomfortable, but fundamentally required elements of their profession.
It's staggering. I was reviewing the case studies for this deep dive, and I kept coming back to this theoretical scenario to highlight the absurdity of this.
Go on.
Imagine an orthopedic surgeon scrubbing in for a highly complex revision total hip arthroplasty. The anatomy is completely distorted, there is significant unexpected bleeding, the operation is spiraling into a nightmare scenario.
A surgeon's worst nightmare.
Right. The surgeon's heart rate is up, they're sweating, the stress is immense. Suddenly, the surgeon steps back from the table, drops their instruments, and announces to the theater staff, you know what, this case is really draining my emotional reserves. It is negatively impacting my mental health. I need to honor my boundaries, so I'm going to scrub out and go to the staff room for mindfulness session.
If a surgeon executed that behavior in an operating theater, it would result in an immediate referral to the medical council for gross misconduct.
Immediately.
We instantly recognize it not as self-care, but as severe patient abandonment. Yet we routinely tolerate slightly less dramatic, incremental versions of that exact same behavior playing out on the wards, in outpatient clinics, and in departmental administration.
And we struggle to challenge it because the clinician is wielding that protective shield of wellness.
Exactly. And hospital leadership is terrified of being accused of fostering a toxic environment.
Because if you challenge the avoidance, you are immediately branded as a toxic, old-school dinosaur who is entirely dismissive of mental health struggles.
It is a phenomenal, almost impenetrable defense mechanism.
It really is. We need to systematically differentiate between a structural boundary and weaponized avoidance. Let's look at some specific, contrasting clinical scenarios to make this concrete for the listeners. Let's start with out-of-hours communication and pagers.
Good. Consider the first scenario. You are officially off rota, you are not on call, and another fully qualified doctor is carrying the emergency pager.
Okay.
You choose not to answer work-related emails or respond to non-urgent queries from colleagues during this recovery window.
Right.
That is a highly functional boundary. You are systematically protecting your central nervous system from chronic sympathetic arousal so that your cognitive processing speed and fine motor skills are fully restored for your next scheduled operating list.
Makes total sense.
Yeah, consider the alternative scenario. You are actively on call, you are holding the emergency pager, it is 3:00 a.m., you are deeply fatigued, and you feel a huge wave of overwhelm. You intentionally ignore a page from the ward because you feel you need self-care in that specific moment. That is not a boundary, that is pure avoidance.
And the systemic difference between those two is staggering.
Mm-hmm.
In the first scenario, the architecture of the hospital rota protects the patient. Another doctor is holding the responsibility.
Exactly.
But in the second scenario, the patient is left entirely exposed to clinical harm because the individual clinician unilaterally collapsed the structure.
Spot on. Let's move away from acute clinical care for a second and look at career management and departmental citizenship. Because departmental citizenship is where avoidance is most frequently disguised as a boundary.
Give me an example.
Scenario 1. You are invited to join a hospital committee focused on IT procurement. It has absolutely no bearing on your clinical subspecialty, it misaligns with your strategic career trajectory, and it will consume 10 hours of administrative time a month.
Okay.
You decline the invitation to protect your time for more relevant clinical research. That is a strategic boundary.
Very sensible.
Scenario 2. You flatly refuse to take on necessary specialty teaching responsibilities. You decline to mentor the registrars, you refuse to deliver the core curriculum lectures, and you claim that teaching infringes upon your work-life balance.
Oh, I've seen this.
However, you are perfectly happy to reap the financial benefits, the clinical lists, and the societal status of being a senior consultant within that exact specialty.
Yeah.
That is avoidance.
That specific scenario describes a parasitic approach to a medical specialty. I mean, the clinician extracts the status and the resources from the ecosystem, but they refuse to contribute to the survival of the ecosystem by training the next generation.
Exactly.
They label their refusal as a boundary, but it is simply an offloading of necessary labor. What about the daily outpatient clinic?
The outpatient clinic is a perfect microcosm for this. Scenario 1. You engineer your day efficiently, you manage your consultation times with discipline, and you leave the clinic on time at 5:00 p.m. on the vast majority of days. That is a functional load-bearing boundary. Scenario 2. You establish a rigid, inflexible rule that you leave at 5:00 p.m. regardless of the clinical reality. On that rare, exceptional day when a complex patient presents with a genuine, evolving crisis at 4:50 p.m., you execute a poor handover or simply walk out the door, citing your boundaries to the nursing staff.
Wow.
That is avoidance.
Because walking out on a patient in crisis fundamentally degrades your clinical capability over time. It habituates the brain to evasion rather than problem solving.
It does.
And we have to address the macroeconomic and systemic impact of this avoidance,
Yeah.
because it does not occur in a vacuum. When one clinician decides to opt out of the difficult, emotionally taxing parts of the job under the guise of setting boundaries, the clinical work does not magically evaporate.
It never evaporates.
The complex patients still require stabilization. The registrar still requires supervision. The difficult, litigious family still requires a senior update.
The burden simply shifts horizontally. It rolls directly onto the shoulders of their colleagues. And the colleagues who absorb this displaced workload are invariably the ones who are already predisposed to the martyrdom complex. So you eventually create a bifurcated department.
A completely split culture.
Right. On one side, you have clinicians using avoidance boundaries who are highly rested but are actively degrading the clinical integrity of the specialty. And on the other side, you have the dedicated clinicians carrying two people's workloads whose central nervous systems are burning out at an exponentially accelerated rate.
The tragic irony is that the language of boundaries, when misused as a tool for avoidance, actively manufactures the exact burnout it claims to prevent. It just maliciously offloads that burnout onto the colleague standing next to you.
Spot on. The true professionals are the ones who possess the rigorous self-awareness to differentiate between the two.
Right. So having stripped away the fake boundaries and identified avoidance, we must define the core defenses. What are the vital, non-negotiable territories of a mid-senior professional's life that absolutely must be defended with robust structures to sustain a 3-decade career in high-stakes medicine?
We must shift from diagnosing the systemic failure to engineering the framework for survival. Because there are specific physiological and psychological categories that require aggressive protection. If a clinician fails to defend these, the statistical probability of surviving a 30-year career without severe mental health collapse, divorce, or clinical malpractice is incredibly low.
So what's the first one?
The first and most physiologically non-negotiable boundary is sleep.
I mean, claiming sleep as a boundary sounds incredibly pedestrian, almost too basic to mention to a highly educated medical audience.
You would think so. But within this specific culture of medicine, treating sleep as a protected asset is practically a revolutionary act.
That's sad, that's very true.
It is revolutionary because the entire architecture of medical training spent the last century weaponizing sleep deprivation as a proxy for clinical dedication.
A badge of honor.
Absolutely. We must examine the neurobiology to understand why this boundary is paramount. During deep sleep, the glymphatic system in the brain actively clears neurotoxic waste products, including amyloid beta, which accumulate during waking hours of high cognitive demand.
Literal neurotoxins.
Literal toxins. When a clinician chronically truncates their sleep window, they are operating with a buildup of neurotoxins. The cognitive processing speed, the ability to execute complex pattern recognition during a diagnosis, and the fine motor control required in the operating theater at hour 13 of a shift, they are radically degraded.
It's terrifying when you put it like that.
And furthermore, the resilience to sleep deprivation drops precipitously as a clinician ages. A 50-year-old consultant cannot biologically absorb the same sleep deficit as a 25-year-old registrar without severe cognitive penalty.
And beyond the sheer technical and cognitive degradation, chronic sleep deprivation fundamentally alters the clinician's personality.
It does.
It dictates emotional regulation. The prefrontal cortex loses its ability to effectively inhibit the amygdala. So a sleep-deprived clinician is highly reactive, irritable, and prone to snapping at the nursing staff. They experience a profound reduction in clinical empathy.
Exactly. So defending the sleep window, putting the phone on Do Not Disturb when not officially on call, and refusing to review routine charts at midnight is not a wellness luxury. It is a foundational safety protocol that makes the clinician technically sharper and significantly less prone to error.
Right. So if sleep forms the physiological foundation, the psychological foundation has to be the protection of close relationships.
Yes, because the intense, unrelenting demands of acute medicine consistently extract the highest quality of clinicians' emotional bandwidth, leaving what is often described as the leftover version for their families.
The leftover version. That is a devastating phenomenon. A consultant gives their absolute best, most patient, most empathetic, and sharpest cognitive self to their patients, their trainees, and their hospital management for 12 unbroken hours.
Everything they have.
Right. They navigate complex emotional traumas, deliver bad news with grace, and maintain absolute focus in theater. But by the time they unlock their front door at home, their capacity for emotional regulation is entirely depleted.
Empty.
Their spouse, their children, and their closest friends receive an irritable, exhausted, emotionally blunted shell. They get the absolute dregs of the clinician's humanity.
And the neurobiology of compassion fatigue explains this perfectly. Empathy requires immense metabolic energy. When a clinician is constantly exposed to patient suffering, the anterior cingulate cortex eventually downregulates the empathic response as a protective mechanism against psychological trauma.
It just shuts off.
It shuts down to protect you. But if this state is brought home consistently, it predictably erodes marriages and dissolves close friendships. The divorce rates and social isolation metrics among senior surgeons are a statistical testament to this.
It's a huge problem in the field.
So setting a rigid structural boundary around time with the people closest to you is an absolute requirement for long-term survival. It means transitioning mentally before entering the house. It means categorically refusing to review pathology results on your phone during your child's school event.
You must protect that domestic time with the same ferocity that you protect a sterile field in the operating theater.
Brilliant way to phrase it. Yes.
Because losing that anchor to the outside world strips away a massive component of the clinician's humanity, which paradoxically makes them a worse healer. And this directly connects to the third category that requires an impenetrable structural boundary: the non-clinical identity.
Right.
The absolute necessity of maintaining a facet of your psychological self that is entirely insulated from the medical profession.
The fragility of the monoculture ego is a massive vulnerability for doctors. You must cultivate a hobby, an interest, or a community where your societal value is absolutely uncoupled from your medical output. You need to exist in an environment where no one cares that you are a consultant orthopedic surgeon.
Whether it is playing the cello in a terrible amateur orchestra, restoring vintage motorcycles, or competitive rowing, protecting the hours required for that non-clinical identity is not a frivolous indulgence.
Not at all.
It is a critical psychological hedge against the inevitable disasters of a clinical career.
In a 30-year timeline, catastrophic professional events are a statistical certainty. You will face severe surgical complications. You will likely face litigation. You may face a grueling investigation by the medical council. You will lose patients despite doing everything perfectly.
It's just the law of averages.
Exactly. If your entire psychological architecture, your entire sense of self-worth is entirely wrapped up in the identity of being a successful doctor, a clinical failure translates into a total annihilation of the self. This is the mechanism behind the tragic rates of severe depression in the profession following adverse clinical events. However, if you possess a diversified identity, the clinical storm is contained. You fail at work, but you are still a valued member of your rowing club or a skilled musician. The diversified identity acts as a psychological firewall against total collapse.
So we have established the defenses for sleep, relationships, and non-clinical identity. But we must address the professional boundaries within the hospital walls, because the most critical operational defense for a senior clinician is the prevention of scope creep, specifically regarding contracted hours and administrative burden.
Scope creep is the silent, incremental destroyer of clinical careers. The macroeconomics of modern healthcare systems actively rely on the uncompensated, undocumented goodwill of clinical staff.
They run on it.
They absolutely do. Hospitals are financially incentivized to extract maximum labor from fixed-cost assets, which is what a salaried consultant is. And scope creep never occurs as a sudden, massive demand. No hospital administrator asks a clinician to increase their workload by 20% overnight.
No, they're much smarter than that.
It is entirely insidious. You sign a highly specific contract for 4 clinical days a week. During a winter pressure crisis, there is a massive backlog in the outpatient clinic. You agree to run 1 extra list on your day off to help the department. You do it once.
But the hospital administration observes that the backlog was cleared without the financial cost of hiring a locum. The emergency measure is slowly integrated into the baseline expectation. The winter pressure becomes a permanent state of backlog.
Yes.
And your 4-day contract quietly, unofficially morphs into a 5-day reality, entirely without corresponding compensation, recognition, or allocated recovery time.
And the micro creep is equally destructive. The clinic is officially scheduled to conclude at 5:00 p.m. However, due to deliberate algorithmic overbooking by management to maximize throughput, the clinic routinely bleeds into 6:45 p.m.
Every single day.
Every day. The administrative creep is relentless. Endless compliance modules, mandatory audits, and emails that expand far beyond the actual requirements of patient care. A senior clinician must execute a crucial psychological reframe here.
Which is?
Pushing back against unnecessary administrative creep and refusing to allow a 4-day contract to become 5 is not you being difficult or uncooperative. It is an execution of essential, high-level clinical leadership.
That's a huge reframe. Refusing to absorb the system's failures is an act of leadership, because if you allow the hospital architecture to exploit your goodwill, you are implicitly signaling to the administration that they can exploit your junior registrars.
Caught on.
You are normalizing the dysfunction and setting a toxic cultural baseline. By holding the line on your contracted hours and aggressively pushing back on administrative bloat, you force the institution to confront its own operational inefficiencies rather than allowing them to use your unpaid exhaustion as a cheap plaster to cover their systemic failures.
Exactly. This framework of structural boundaries, defending sleep, relationships, identity, and preventing scope creep is highly robust. But we must introduce the ultimate caveat.
Okay.
There is a specific circumstance where boundaries must be instantly dissolved. A clinician must never attempt to set boundaries against engagement with patients in critical moments of genuine biological need, nor against supporting colleagues who are genuinely drowning.
Right. When the system truly fails, or the biology unexpectedly collapses, when the patient in the recovery room suddenly drops their blood pressure and goes into hemorrhagic shock, or when your registrar is completely out of their depth in theater during what was supposed to be a routine procedure and pages you for emergency assistance.
Yes. In those moments, the structures drop. The 5.00 p.m. clinic rule vanishes. The language of protecting my capacity evaporates. You step in and take control.
Because those unexpected critical events are not administrative interruptions to the workflow. They are the fundamental, irreducible reason the medical profession exists. A boundary that actively prevents a clinician from acting decisively in a true biological crisis is a boundary that has severed the clinician from their professional oath.
And the profound paradox of this framework is that if you have rigorously defended your sleep, your emotional relationships, and your time against administrative scope creep on the 99 normal days, you will actually possess the physical energy and the cognitive reserves required to drop everything and perform at the highest level when that one true crisis occurs.
That is the whole point, isn't it?
Yeah.
But having the theoretical architecture of a boundary in your head is entirely useless if you cannot enforce it in the real world.
Oh, absolutely.
The moment you attempt to articulate these boundaries to a stress-charged nurse or a hospital manager whose sole metric is throughput, the theory often falls apart. So how do we execute this? What are the precise tactical communication principles required to establish these structures without causing a departmental meltdown or being labeled as hostile?
The tactical execution is where the vast majority of clinicians stumble. They achieve the internal realization that their current workload is unsustainable, but they completely lack the linguistic vocabulary and the strategic timing to implement the change.
They don't have the script.
Right. The first unshakable principle of boundary communication is that the phrasing must be direct, it must be warm, and it must be highly specific.
Highly specific, because vague, emotionally vulnerable phrasing is incredibly common and entirely ineffective.
It's the default for most people.
A clinician feeling overwhelmed will often approach their team and say something like, "Listen, everyone, I am feeling really burned out and exhausted lately, so I am trying to be better about setting boundaries around my personal time. If you could try not to message me as much in the evenings unless it is really important, I would really appreciate it."
It sounds like a plea for mercy rather than a professional directive.
That's exactly what it sounds like.
And that phrasing actively invites pushback and failure. Because it is vague, the multidisciplinary team has no quantifiable metric for what as much or really important actually means. One nurse's definition of important is entirely different from another's.
Completely different.
Furthermore, because the boundary is framed entirely around the clinician's subjective emotional state, I am burned out, it makes the operational rule conditional on feelings. Feelings are subjective, which means hospital administration will view the boundary as open to debate.
So what's the alternative? Give us the direct, warm, and specific version.
Contrast that disastrous attempt with this. I want to ensure I am operating at maximum focus for our morning surgical rounds, so I do not return non-urgent messages after 7:00 p.m. Please hand over any pressing ward issues before that time.
Brilliant. The structural difference of that sentence is brilliant. The directness, I
Yeah.
do not return messages, the warmth and professional justification, I want to ensure I am operating at maximum focus, and the absolute specificity. After 7 p.m., it establishes a concrete operational parameter that leaves zero room for subjective misinterpretation by the staff. And crucially, there is absolutely no apology embedded in that directive.
The psychology of the apology within hierarchical power structures is critical to understand here. High-achieving medical professionals are often plagued by imposter syndrome and a deep-seated fear of litigation or formal complaints.
They really are.
As a result, they habitually apologize for establishing basic operational parameters. They say, I am so sorry to be difficult, but I really cannot take on another committee right now.
Yeah.
The boundary does not need to be defended, it simply needs to be communicated. When you embed an apology into a boundary, you are subconsciously signaling to the administrator or the colleague that you feel guilty about the restriction. You are telegraphing that you do not fundamentally believe in your own right to establish that structure.
And if the clinician projects guilt and a lack of conviction, the hospital administrator, who, let's be honest, is professionally trained to identify and exploit operational inefficiencies, they will immediately sense the vulnerability.
Oh, they smell blood in the water.
An apology is blood in the water. It acts as an open invitation to negotiate the boundary away.
Yeah.
The administrator hears the sorry and applies pressure. Oh, please, we just really need your expertise on this. It will only take a few hours a month. Be a team player.
Yep.
If the clinician simply states, I am unable to join another committee at this time as it conflicts with my current clinical focus, they have stated an objective fact. There is no negotiation because there is no vulnerability offered.
Exactly. State the parameter as an operational fact, not a negotiation point. But we must also address the behavioral conditioning required when making exceptions.
Right, the durability piece.
As we established, a healthy boundary is durable but not rigid. Biological realities will force exceptions. However, communicating an exception without accidentally destroying the entire structural rule requires a highly sophisticated linguistic tactic. I call it naming the exception.
Naming the exception. Okay, give me an example in a behavioral context.
Let's say a consultant establishes a transparent rule that they do not take clinical phone calls on weekends when they are off the rota.
Fair enough.
But they happen to have a highly unstable post-operative patient on the ward whom they're deeply concerned about. If the consultant simply answers their mobile phone on a Saturday when the charge nurse calls regarding that specific patient, they have inadvertently ruined their own boundary.
Really? Just by answering it?
Yes, precisely. By answering the phone without context, the charge nurse's brain simply registers. The consultant answers their phone on Saturdays. The original boundary is completely overwritten in the nurse's mind.
Oh, I see.
The nurse will immediately assume the weekend boundary no longer exists and will likely call back an hour later regarding 3 other minor, non-urgent issues. The unstated exception silently destroys the rule.
So what's the correct tactical approach?
The correct approach is to name the exception proactively, before the weekend begins. The consultant must go to the charge nurse on Friday afternoon and explicitly state, as you know, my standard operating procedure is that I do not take calls on weekends. However, for the patient in bed for, due to their specific vascular risks, I am making a deliberate exception. I want us closely connected on this specific case. Ring my mobile directly if their parameters deviate.
By explicitly vocalizing the phrase, my standard operating procedure is that I do not, the consultant is actively reinforcing the structural boundary at the exact moment they are stepping across it.
Spot on.
The named exception fiercely protects the rule through behavioral conditioning. That's incredibly smart. And the final tactical element of execution is the timing of the communication, isn't it?
Yes. The physiological state of the nervous system during communication dictates how the message is received. These explicit conversations regarding boundaries must occur when both parties are in a parasympathetic state of calm, proactive planning. They should be communicated during formal orientation, at the commencement of a new clinical rotation, during a scheduled departmental meeting, or in a quiet, controlled environment.
Because if a clinician attempts to establish a boundary while shouting across a chaotic trauma bay at 2 a.m., with alarms blaring and adrenaline surging, the message will never be received as a professional structure.
It's biologically impossible.
In a state of sympathetic overdrive, the brain interprets any restriction as a direct threat. It will be received by the team as a hostile ultimatum or a personal attack. Boundaries communicated proactively in a state of calm are processed simply as the professional operating manual for how the clinician functions best.
But here's the thing. The external execution, the perfectly crafted, warm but direct phrasing, the proactive timing, the management of administrators, it is entirely useless if the clinician fails to execute the final and most grueling step of this framework.
Which is,
All external communication collapses if the clinician avoids the inner audit.
we must confront the mirror. Before a clinician can dictate a boundary to the hospital, they must audit their own internal psychological motivations with absolute, unflinching honesty. We are talking about the duality of the medical ego.
The psychological challenge of rigorous self-reflection is the most punishing aspect of this entire process. It is infinitely easier for a clinician to blame the systemic failures of the hospital management than to dissect their own neuroses.
Definitely.
The clinician must brutally examine their daily practice and ask a profoundly uncomfortable question. Which specific elements of this clinical work are genuinely degrading my physiological and cognitive capacity to be a safe, effective doctor, and where elements am I only labeling as draining because I simply, quite frankly, want to avoid doing them?
That is a harsh question, because it forces the clinician to confront a massive internal war between two opposing egos.
Yes, it does.
On one front, we have the avoidance ego, which constantly attempts to hide from the monotonous, legally risky, or emotionally taxing elements of the job by wrapping the evasion in the socially acceptable language of self-care and boundary setting.
Exactly.
And on the other front, we have the martyrdom ego, the deep-seated, historically conditioned savior complex that continuously whispers that we are the only one capable of saving the patient, that delegating is a sign of weakness, and that staying on the ward until midnight confers absolute moral superiority.
And the human brain is an unparalleled machine for rationalizing its own behavior. Medical professionals, because they are highly educated and trained to appear entirely objective, are actually uniquely terrible at auditing their own subjective motivations.
Really? Why is that?
Because a clinician will effortlessly convince themselves, I am not avoiding the difficult conversation with the grieving family. I am simply prioritizing my administrative flow to ensure patient safety across the broader ward.
Wow. It's an elegant lie.
Oh, it's a very elegant lie. Because our capacity for self-deception is so vast, especially under the chronic stress of healthcare, the inner audit cannot be conducted in total isolation.
The clinician cannot rely solely on their own internal monologue because the monologue is biased. They require a highly calibrated external mirror to reflect the reality of their decisions.
Exactly. Maintaining this level of rigorous psychological honesty over a 3-decade career requires formal, structural intervention. I strongly advocate for the necessity of an external perspective.
What does that look like in practice?
This could take the form of a professional executive coach who deeply understands the macro dynamics of healthcare systems. It could be a highly qualified therapist. It could be a carefully selected senior clinical colleague who exists entirely outside of the clinician's direct reporting hierarchy, with whom they establish a pact of brutal, unvarnished honesty.
That makes sense.
At the absolute minimum, it requires a formalized, written, reflective practice that forces the clinician to articulate their decision-making matrix.
You need someone who possesses the authority and the insight to look you in the eye and ask, are you actually deploying a structural boundary to protect your cognitive bandwidth, or are you just running away from confrontation with the new hospital director?
Spot on.
Doing this inner audit is incredibly painful and fraught with psychological blind spots, but the long-term consequence of avoiding the audit is significantly worse. It leads with absolute certainty to either severe moral injury driven by chronic avoidance or total physiological collapse driven by unchecked martyrdom.
So we must synthesize the framework we have constructed today. We began by examining the wild, unhelpful pendulum swing between the modern cure-all wellness camp and this historical martyrdom camp.
Now we found the middle.
What we have engineered is a highly functional, load-bearing middle ground. Boundaries are not an HR-approved method for checking out of clinical medicine. They are the essential biomechanical scaffolding that sustains high-level, safe clinical care over the entire lifespan of a medical career.
Healthy structural boundaries are the mechanisms that allow a clinician to fiercely defend the absolute non-negotiables. The neurobiological necessity of sleep, the emotional anchor of close relationships, the psychological firewall of a non-clinical identity, and the economic protection against administrative scope creep.
Yes.
But they are never, under any circumstances, weaponized as an excuse to abandon a patient in a moment of critical biological failure or a colleague who is genuinely drowning under the weight of the system.
Navigating this messy middle requires constant proactive recalibration. It requires direct, specific communication devoid of apology. And above all, it requires the rigorous, uncomfortable self-honesty to constantly evaluate one's own motivations.
As we conclude this deep dive, there is a final, highly provocative challenge we want to leave you with. Something to dissect during your commute home or before you scrub in for your next list.
I challenge every clinician listening to identify just one specific boundary that you have established in your professional life within the last month. Identify one rule that you have confidently labeled to yourself or your team as healthy or protecting your peace.
Just one.
Bring the exact parameters of that boundary to mind right now. Now, subject it to the ultimate test. Look at it with absolute, unflinching honesty, strip away the wellness vocabulary, and ask yourself, is this specific boundary actually making me a sharper, safer, more capable clinician over the long term, or am I simply using the language of boundaries to hide from the work?
The survival of your career and the safety of your patients depends entirely on how honestly you answer that question. If this structural framework has helped you rethink how you engineer your time and protect your clinical practice, please take a moment to rate Deep Dive Ortho and share this deep dive with a colleague whose scaffolding might be starting to fracture under the weight of the system. We will see you next time.